Assalamu alaikum, everybody. My name is Gulrez. I'm the current chair for APPNA YPC this year. We are doing this research session focusing on quality improvement and case reports and other basic building blocks of research under the umbrella of PRISM, which is a new initiative that was started this year. We wanted to focus more on our other aspects of our applicants, apart from just their application process to the USMLE. So PRISM includes professional development, interpersonal skills, research, mentorship, and other aspects that we will try to cover under this program. It's a well-rounded curriculum that we are building on. This is our first year, might be a little less polished, but hopefully it will continue to build in the next few years and can show up as a very strong improvement to our overall portfolio. Without any further delays, we'll get on with our program. This is going to be an interactive program, so be prepared to look at the chat, put in your answers, be prepared to open your camera up and given access to speak, ask questions. We'll try to keep it as interactive as possible, and I'm not hoping to put the recording on because I hope this becomes an exercise that we do every year or maybe every few months. But we'll see how that goes. But before I would like to introduce our panelists. I will start off with Dr. Namira Jamshed, then I will go to Mustafa, Junaid, Anam Hamid, and then Faisal Akram.
Dr. Shafiq.
Dr. Shafiq as well. He hasn't turned on his camera yet. So, Dr. Jamshed, over to you.
All right. Assalamu alaikum, everyone. So we're just going to dive into this. What I did was I've made the presentation extremely simple. So just to give you background, I now have certification in quality improvement and patient safety, and we teach that to our residents. I'm going to give you simple steps from the perspective of someone who's applying for residency. Okay. I'm assuming most of you that's your plan. Now, if you want to go a step above that, where you're already doing residency and you want to do a big QI project, please reach out to us. And so some of this may be very basic for our panelists, but hopefully it'll be a good interactive session. All right, so let me just share my screen and we'll go ahead and start. Okay, so basically we're going to talk about how to do a quality improvement project. We'll give you a very simple guide, and our hope is that you will implement this. We're going to talk about what QI is versus research, know what the steps are, how to complete a small QI project, and know how to present it for residency. So just a raise of hand. How many of you have done any of this? Led one, participated, not? I just want to get an idea of where people are. Okay. Anyone else? No one wants to share? Okay, no. Okay. All right. So Dr. Shafiq, you have your hand raised.
Oh, I think you asked that, have you ever participated in a QI project?
Yes.
So yes, I did.
Of course. All right. So majority of you have no experience, which is actually great because we can start very simple. So why is quality improvement important? So quality improvement, if you have done that or are going to do it, is going to show that you are thinking about systems. It also shows initiative. And then it also shows that you have awareness of patient safety. In addition, for our ACGME expectations, when you're a resident, we expect this, that you will be doing a quality improvement project. It is required, I think, by all residency programs. So if you have some background and you come with that is very helpful, especially when you're applying for residency. So this is QI. QI is more of a local system. So you focus more on where you are. It's a much smaller scale than research. It's a very rapid cycle. You keep going through it, keep going through it until you improve, and then actually you keep improving. And it's much more practical than research, in all honesty, because it's going to have practical implications. Research is more of improving generalizable knowledge. It's always hypothesis driven. You cannot do, you do not need a hypothesis with QI. With research, you need a hypothesis. And then research typically will require IRB. And in most of our academic organizations, even QI needs an IRB application, but it doesn't need IRB approval if they agree that this is a QI project. You can go ahead and start it fairly quickly. And most research has a longer timeline. QI is very, very rapid and usually shorter because you're looking at something and then you're looking at the outcomes. All right. So the model is, starting to focus on what is it that you're trying to accomplish. Okay. How will you know that the change is an improvement? And what change can we make? And then I'm going to, we're going to go through examples. All right. So let's start with step by step. Number one, start with a problem, right? You have to think about what a QI problem is. It has to be very specific. It cannot be generalizable. You have to be able to measure it. It cannot be a zebra or something that's rare. And most importantly, it has to be fixable. So it's not that you're just collecting data. Okay, this is not good or this is not working. You have to be able to find that problem and be able to fix it. So some of the examples are low vaccination rate. And I've tried to, by the way, make this very Pakistan oriented so that to see what we have available there. In the US, delayed discharge summaries. Patients are discharged from the hospital, but the discharge summaries never get to the primary care physician or the nursing home. There's a huge delay. Very poor diabetes control documentation. Patient has diabetes, but there's no documentation of what they're taking. We do a foot exam, what the hemoglobin A1C is, and then most importantly, incomplete MedRec. MedRec is basically what is it the patient is taking, and what do you have in your chart. So some of this, all of this technically does apply to both the US and Pakistan, but these are sort of very important things that we do in general to take care of patients. So this is the first example. Okay. So what is the problem with vaccination rates? So we're talking about the US, let's say, or Pakistan. You have low flu vaccination rates in older patients. Okay. This is your baseline. Now, you have to find what the baseline is. People sometimes in meetings will throw out things there. Yeah, we don't do any flu vaccine, we don't do any pneumonia vaccine. No. What do you mean by we don't know? Do you have a number to back it up? So you will go to the system and say, what is our baseline vaccination rate for flu vaccine? Okay. So in this case, we figure out it's 45%. Then you come up with an aim statement that you are going to increase the flu vaccination rate in patients over the age of 65 from 45% to 70% in 3 months. So, what is the measurement here? You went from 45 to 70, and you have a defined period, which is 3 months. And then you have to come up with an intervention. How are you going to, get to that goal? We can, if you have electronic records, you can do EMR reminders. If you don't have that, you can write a script for the staff. You can also do chart review before the patient is coming. And then you'll measure how many vaccinations you did in a week and how many people refused. You always have to count people who refused as well. Otherwise, it may look like you didn't do much improvement, because if you include those people, that might skew your data. So that's one example. Second example is what we talked about, improving diabetes foot exam. Same thing. The problem is that foot exams in diabetic patients are not documented, even if you were doing it. Baseline, only 30% of diabetic patients have documented foot exam in the past year in your clinic or in your organization. Your aim is that you're going to increase it from 30% to 75% in 3 months. Now, notice in both examples, we've used a short duration. We're not talking about 1 year. We're not doing research. We're talking about 3 months. You're doing a specific intervention. Maybe you add a checkbox to your OPD sheet, right? You have papers, and we do that. I know in Aachen, we do that as well. You might have a reminder poster in the clinic. Maybe you put a poster in. We did that with one of our QI project. Or you may have a nurse training for the nurses who are there. And then your measure will be an audit of diabetic charts and see if there was an improvement with all these interventions. Last example is improving antibiotic stewardship. So a lot of people take antibiotics even when it's a viral infection, and we want to reduce that antibiotic misuse. So the problem is that you'd identify the problem that prescribed for viral upper respiratory infection, baseline 80% receive the antibiotics. So your aim this time is different. Your aim is to reduce antibiotic prescription from 80% to 50%. And how will you do that? You can educate the patient. You don't have to do all three. You just pick one. Patient education, resident reminder protocol, some kind of checklist criteria, and then you weekly review the upper respiratory tract infection prescriptions. How many people got antibiotics. So these are just some examples that we talked about. So we'll start with, if you look here, we're talking about the aim statement. The aim statement is really important. So your first step is you have the baseline data. Then you must have an aim statement. And what the aim statement is basically who, what, by how much, and by when. So I know you guys, some of you may have already seen the slides. I want everyone to write an aim statement for, I don't know, pick something and write an aim statement. Maybe one of the panelists can give us an example. So let's see. We had our older patients in the house call program. Our baseline pneumonia vaccine rate is only 40. Actually, it's maybe 40%. So let's say that we want to create an aim statement because we want to improve the rate of pneumonia vaccine. So I want all of you to write an aim statement. Who is going to do it, right? What are you going to do? What, by how much, and by when? Take 2 minutes to do this.
You can write it in the chat. And to be honest, this is a good time for you to start practicing things. So don't be shy,
Yes.
right?
Yes.
Whatever you want,
Yes.
nobody's judging you here.
Yeah. I can tell you when I started my certification, all of us are, experienced, and many of us did not know how to write a good aim statement. So 42% is the baseline. Good. Delay. Oh, okay. All right. Delay and mistakes in sign outs while changing shift. So that's a problem that you are dealing with, Dr. Rifat. But what is your aim statement to improve that? Pick one. Don't do delay and mistakes. Increase pneumonia vaccination in nursing home from 40% to 70% in 3 months. Okay, very good. 25% to reduce cap rates and hospital admissions by 10%. Now, let's look at that. I think here, this is an example of where you're trying to do too much. We don't want a QI project where you're trying to do too much. You do not want to increase the rate to reduce the cap rate and the hospital admission by 10%. Okay? You want to be very simple. Just pick one thing. So something like what is already written, 40% increase, and only one of you put 3 months. The duration is extremely important. Your aim statement must include a duration. Okay. So Dr. Kumar, you want to decrease the unnecessary use of PPI in ICU patients. Great. I need you to create an aim statement for that. What is your aim going to be? Increase compliance to sanitizing hands before entering and exiting patients' rooms by 40% in 6 months. Okay. And again, try to see if you just want to increase DVT profile by 70%. Okay, good. I think everybody is getting the hang of it. So that's great. So this is an example of increase influenza vaccination rate in adults over 65 in whatever clinic from 45% to 70% in 3 months. So very similar to what you guys have done here. All right. So this is how you write a strong aim statement. It has to include the population. So in some of the aim statements that you guys put, there's no population. You said increase pneumonia vaccine. One of you did put nursing home. That's good. But who are you going to increase pneumonia vaccine in? It could be children or it could be adults. So you have to say increase pneumonia vaccination rates in adults over the age of this. Then you have to look at outcome. what is it that you're trying to achieve? So a lot of you already put vaccination rate. Then you have an improvement target, like 25% to this, 40% to 70%, and finally a timeline. So this is a template that you guys can use, and Dr. Emmett can share this as well. We can, and I'm happy to share this everywhere. So your goal should be: we aim to improve this in X population from this percent to this percent by whatever time it is. Okay, and so see here we aim to improve influenza. Here we put influenza vaccination rate in population is patients over 65 from 45% to 70% in 3 months. Okay, so this is how you all need to start thinking about QI projects. I'm telling you, it is probably, if you, wherever you are, it doesn't matter, Pakistan, here, it is I don't want to say easy, it's the most practical thing to be able to do and get published. And when we talk about publication, I'm talking about posters. I'm talking about abstracts. We're not talking about a manuscript here, but it shows that you as a physician or a student have thought about that. You went to the clinic and you saw something, and then you thought about, what is it that I can contribute to improve this? Okay. All right. So you have to, so we went through the steps, right? You have your aim statement. The next is baseline. You cannot improve what you don't measure. You have to have a baseline, right? So your baseline needs to be there. And then you have to think about, what is it that you're going to measure? Are you going to measure outcome like 40% to 70%? Are you going to improve measure process? Somebody mentioned sanitizing hands, in and out. Here we have a process for when we put central lines, or are you just going to have sort of try to balance things? So figure out what your measure is going to be. So, and then you have your intervention. So you now have your aim statement, you have your baseline, how you're going to measure it, what is your intervention going to be? So if it's vaccinations that you want to improve, your intervention is going to be reminder calls, could be electronic medical record prompts, could be staff education, could be a checklist. We use checklists, and some of you might be doing family medicine. We use checklists for prenatal care. In the prenatal care, there's a lot of things that need to be done, and we have a checklist. And we go through the checklist. And when you don't have a checklist, then you have a problem. Sometimes you have a checklist, but the process is the problem. So I had one case where patient had a checklist, got the blood test that she needed to get done, but there was no follow-up. And because there was no follow-up, the blood work was abnormal. That needed an intervention, that we needed to let the patient know. That did not happen. Because that did not happen, now you have a birth of a child who is delayed in their mental capacity. And now you're leading to in the US, it would be a lawsuit, which it was. But in Pakistan, you missed what needed to be done. So interventions can be at different points. So all the panelists will be familiar with this. We call this the PDSA cycle. This is how we do it. We plan what we're going to do, then we do it. Okay, so you plan, then you do it. Then we study that what we did, what happened with that, and then we act on the result. That's why we call it a cycle. You just keep going. So let's say that you started with let's say you started here. You plan that you're going to implement your aim statement. Okay, we are going to increase vaccination rate. We've already discussed. The do is that you are going to review the chart ahead of time and seek a vaccination hui hai ki nahi, and then you're going to. So then you do that in the clinic for 3 months, and every month you don't wait for 3 months. You do this every week. You have to do the audit. So you study it in 1 week, and you find out that maybe 5 patients is what you identified. Then you say, well, you know what? that's not working. We need to go ahead beyond this. We need to do something else. Then you act on that. Then you plan again. And then you keep doing this until you reach your goal. So that's how a cycle works. And that's how QI works. Okay. Now, when you have done your project, you are going to present it as a poster. Um, you're going to have your background. Why did you think that this was a problem? Why is it so important to think about vaccination rates? What is your aim statement? What, how did you do it? How did you come up with a plan? What was your intervention? What results you had and what lessons you learned? It's a very simple poster format, and that's what you do. Now, just to get back to residency, what residency programs look for, and this is for all residencies, all subspecialties, is not just internal medicine. Programs care about initiative, teamwork, that you understand the system, and that you also reflected on it, right? We are not looking for fancy statistics. We're not looking for large sample size. We're looking for publication, not really looking for publication necessarily, but we're looking for you have submitted, and if it was an abstract or was, poster that was accepted, that's for QI is good enough. So it just shows you don't have to have a manuscript. For a manuscript, you would have to have a lot more than what I've shared. Common mistakes we make is trying to make it too big. I'm not going to do just one clinic. Let me do the whole hospital. No, you don't need to do that. Focus on one clinic and get it better. Calling QI research. If you have a QI project and you put it in your CV that is research, is going to be a mistake. You can't have a QI project without baseline data. So a lot of times people will say, we did a QI project, but there's no baseline data. There's no measurable aim. And then most importantly, there's no reflection. What did you learn from the whole experience? What did you do differently? What happened? Maybe you do a QI project and it failed. You have to have a reflection of why it did not work. Okay? All right, so let's start. We're going to do one case and then we'll end and then we'll let other panelists comment. So let's say that it's a busy morning in Karachi because I'm from Karachi. You're a house officer in a government public hospital in OPD. You have 120 patients scheduled in the whole OPD. There's only one consultant, two trainees. You have limited nursing support. There's paper charts, no EMR, no appointment system, and you notice something concerning. So for all of you who have worked in this kind of a system, can you put in the chat if you noticed something that was concerning when you were a student or intern or MO, anything?
You can raise your hand and we can unmute you.
Oh, wonderful. Thank you. Come on, guys, be brave. It's okay. Just share. And maybe some of the panelists can start so that the other people are.
Let's give Junaid
And
a chance. Junaid,
Miss,
what do you want
Acha,
to
go
add?
ahead, Junaid.
Yeah. So it's a busy morning. First of all, we are understaffed. That is one of the things that's
Mm-hmm.
concerning.
Mm-hmm.
With no appointment system enforcement, another problem is like you might not be able to know who comes first. So somebody who knows someone, that's something very common in Pakistan, may end up seeing the physician earlier versus someone who has been waiting since morning. So these are like biggest two concerns. With no paper charts, you don't have access to their prior history records, like what medications they were on. So that's also a problem.
And you all can, thank you, Junaid. That was very good. You all can go beyond this as well. Just something somebody said, mismanagement. But Dr. Rifat, the mismanagement is a very broad word. You have to be very specific. That's what I talked about. It has to be a very specific thing. Okay. Um, all of you are writing things that are still very general.
Before moving to Mustafa, I want to give a participant a chance.
Mm-hmm.
Bushra, you can unmute yourself.
Hello, thank you for the opportunity. Remembering from my house job experience, first of all, I think there are multiple, patients who are in the same room at the same time. So
Mm-hmm.
there's lack of privacy, I would say. You can hear what the other patient is saying, discussing with their doctor. You are taking one patient's history, another patient is talking to another trainee. It's all happening in the same space. So there's a lot of compromise on, I think, protected health information. Another thing is that because there's, you have too many patients to see, you cannot go through the whole steps, just taking a detailed history, then taking them separately, giving them the time and space for physical examination, going through all the steps. They do not have that safe space to share something that, they might be
Okay.
hesitant in public place. I think these two
That's
things
good,
are.
Bushra. Yeah, that's very good, Doctor. But you want, again, you want to limit it. So if we had to come up with one theme, you can say one theme is privacy, right? You can say that you have, how would you, but remember, whatever you think as well, it has to be something that you can fix. So if you're going to do a QI project on that, you have to be able to fix it. So Dr. Emmett, Gulrez up.
Mustafa wanted to chip in.
Right. One common thing I would see when working in the OPD in civil is the language barrier, different patients speaking different languages, and not having
Mm,
doctors who can speak those languages, which means they don't get diagnosis and care at all. So implementing a system where people speaking languages that other than English and Urdu that get some kind of medical interpretation and get some kind of documented care, increasing the rates of their care delivery from, let's say, 10% to at least 50, 60, 70%.
So
Makes
your
sense.
goal, Dr. Shah, would be to focus on the language barrier or improving the care. You have to pick one, okay? Otherwise, it'll be
Yeah.
too big. So which one? I'm assuming you already did this or you thought about it, but would you pick what might be more fixable? Maybe the language barrier, if you could
Yes.
figure out a way to,
Yes.
nowadays you can use AI and all these things. All right, good. Um,
I
the
don't know,
work
Dr.
is on
Aslam,
staff
if you want
over.
to add anything.
Yeah.
No, I just wanted to share about the QI project that we did during residency. Maybe I'll mention it later, or you want to talk about it right now?
Talk about it, please.
Okay, so in 2018, while I was in residency in 2018, currently I'm a HEMOC fellow here at Cook County. So what we did is we saw a lot of elderly patient population who's coming into the anticoagulation clinic, and they have
Mm-hmm.
very labile INR, and a lot of time they miss their appointments. A lot of time it happens that they get admitted with supratherapeutic INR, or sometimes they are on Coumadin, but we never have achieved a therapeutic INR. So what we did,
Mm-hmm.
me and four other friends, we started a QI project. We were like, we are going to identify how many of the patients we can find from the geriatric clinic and see if we can switch them from Coumadin to Eliquis or Xarelto at that time. So
Awesome.
so this is what we did. We I still remember we were able to figure out 107 patients, and we had a inclusion criteria, exclusion criteria. We didn't include patients whose creatinine clearance was less than 30, or who have a very stable INR. So we were like, they're good for the last 3 months at least. So we don't want to include that. But the patients who had very labile INR, whose kidney function is good, and also not BMI is not above 40. So those are the kind of patients. And obviously, definitely, if somebody has a definite contraindication, like a mechanical heart valve, something, so we're not going to include them. And then we were able to we were able to figure out more than 60 patients, out of this 107 population, who were able to be switched to Xarelto and Eliquis. Then this thing went from geriatrics clinic to primary care clinic, from primary care clinic went to cardiology clinic, and then it became a whole thing in the whole hospital that all these patients needs to be identified so they can be switched because of better compliance, decreased risk. And I met a couple of patients also. They were very happy because they were also my
Yeah.
patients in the primary care setting. So I think that was really helpful and meaningful
So
to see that project.
I have a question, Dr. Aslam. Did you look at I'm assuming you looked at what the baseline rate of anticoagulation was in patients who are eligible, because you must have had to improve it from a baseline to something, right?
So our baseline was the INR was not therapeutic.
Got it. Okay.
So
So
that was
you had
because,
so
yeah.
this was a really good example of what we call a system approach, right? So process approach, I mean. So they created focused on process improvement, and they focused on, this, we're going to improve the process of switching people from INR who have labile. What was your intervention? How did you convince patients to switch?
So we reached out to patients' primary care doctors.
Good.
On my chart.
Awesome.
On my chart, we
Awesome.
reached out to them,
Okay.
and it was like 60, I think 63 patients we were able to identify out of those 107 patients. And then because a lot of times, even if you see in big cities like New York City, the primary care clinics are pretty busy. And they are sometimes patients are coming in like 5 6 problems, and they sometimes overlook the anticoagulation. Oh, this is being monitored by the anticoagulation clinic. But then we had them be the leader. I was like, no, you have to be, you're the primary care physician. If you can convince your patients, and a lot of them patients also,
Right.
but then we took it one step further because a lot of those patients also did not have insurance. They couldn't get Eliquis. So we reached out to the Eliquis rep, and they helped us getting the Eliquis supplies for those patients. So, and then we presented it on our research day also.
That's wonderful. Maybe at the end, everyone can share their QI projects like Dr. Aslam did, so other people can benefit from it. So I'll keep going with the case. So in this case, we just came up with an example. We looked at a problem. So this is not a real case, by the way. So let's say that you had that issue and you discovered that 40% of patients had their blood pressure documented. And this is in the population is 40 years and old, and only 25% had, what did I do? I messed up here. So you look at your baseline, you look at 50 charts, and you document how many people had blood pressure documented, and you define your age. So ignore the last sentence. Then your problem is that blood pressure documentation is inconsistent. Right? That's your problem statement. And why is it important? It's important because hypertension prevalence is high. It's a silent disease. You have increased stroke and cardiovascular risk, and especially even in Pakistan, that risk is just growing. So now you have a situation, you've identified your problem, you've decided that you're going to address this because it's important, similar to Dr. Aslam's example. Then what you do is that you need to write an aim statement. Okay, so I want everybody to write an aim statement. Let me see if I can fix this. I'm going to remove this. Okay, here we go. All right, so it's a OPD clinic. You have identified that you're going to that there's no blood pressure documentation. Your baseline is that you have 40% blood pressure documentation, and your population is 40 years old. Now, I want you all to write an aim statement. We have like 5-10 minutes left, so because we want to give other panelists a chance. So go ahead and write your aim statement for this. And I appreciate all the great examples in the chat group, but majority of them are, again, too broad. Okay, you can do multiple PDSA cycles for all of them. So you have to think of the example that I'm giving you. You have to be very, very specific. So increased blood pressure documentation in people age more than 40, from 40% to 70% in 3 months. Okay. All right. So I want you guys to start learning to say, we will increase or we will improve blood pressure documentation in the OPD clinic in people age 40 or more from 40% to 70% in 3 months. So start using the word we in your aim statement, okay? All right, who's next? Ahmed Ali, good job. Anyone else? You have to practice this. So we will increase the documentation of blood pressure monitoring in patients more than 40 in primary care. Okay, good. 4 months. We will improve blood pressure measurement in adults above. So it's not the blood pressure measurement, Dr. Raza, it was the documentation. So people are measuring it, they're just not documenting. Good. Improve blood pressure document. Okay, good. So I think most of you have an idea. So here's what we did. This is the aim statement: increase documented blood pressure measurements in adult patients over 40 from 25% to 80% within 8 weeks, or 40% to whatever. So this is your aim statement. Then you have to explain how you did it. You reviewed the 50 charts. you counted the blood pressure documentation, and then you calculated a baseline percentage. Okay. We don't have any software. You don't need any software. You don't need any funding for this. It's very simple. You're just counting. Okay. Because your QI project is not 2,000 people. Okay. And then you do, how are you going to fix this problem, right? So you can, some ideas are you can stamp, put a stamp, blood pressure recorded, yes or no. Pakistan mein stamp to aaram se mil jate hain. We've seen it a lot, your yes and no. Or you assign a nurse who measures the blood pressure before patient enters and documenting, or you have a 10-minute team meeting. These are all interventions that you can do. So baseline bhi ho gaya, you've done the aim statement, then you have an intervention, you pick whichever one you want to do, and then you create your PDSA cycle. And your PDSA cycle is this, right? Step one was introduce stamp and nurse flow. Then you do a trial for 2 weeks, not 1 month, not 2 months, just 2 weeks. Then you audit charts, and then you modify. You just keep doing that until you get to your aim. So after 2 weeks, you notice that the blood pressure documentation increased from 25% to 65%. And then after 8 weeks, you notice that it reached 85%. Okay. So then you have to put in your poster or your QI project. What are the lessons learned? Lessons learned were small changes matter. Team buy-in is very important. Measurement drives accountability. Improvement does not require money. There's no funding or money needed over here. Very simple. Now, last slide. What if during your QI project, you discovered that 30% of the patients had newly diagnosed hypertension? So you were doing the QI project just to increase the documentation. But then you realized, but 30% of these patients have high blood pressure. So now your QI project, just like Dr. Aslam pointed out, actually has an impact. Now you have public health relevant. Now you have system awareness. Now you go to the CMO or whatever, your OPD director. Hey, we did this QI project, it's great. However, we've noticed that 30% of these patients have new hypertension and we're not doing anything. So then you take it to your next step. So the QI project typically will end up in knowledge that you get that will help the system as well. But from your point of view, you discovered something exciting. Okay, so I'm going to end here. Like I said, it's a very simple format, step by step. And you all right now should be thinking what QI project I'm going to be doing. All right, wherever you are. Thank you very much for listening.
Thank you so much. Let's go to our other panelists. By the way, love the exercise. Very thought-provoking. I hope all the participants will come up with some more ideas based on this, and we can actually improve the quality of care we deliver back home. So that's the whole purpose of this exercise. Mustafa, do you want to add something?
Hi, assalamu everyone. I'm Dr. Mustafa Shah, currently a third year resident at University of Missouri in Columbia. I'm doing neurology residency. I think Dr. Jamshed went over all the technical aspects of how to run a QA project really well. From my side as a resident, I can just tell you that she's very right in that programs do look for this. For example, in our program, we actually have a requirement as residents to participate in at least one QA project and one patient safety project during residency as a requirement for graduation. And I'm sure this applies to other residencies as well. So, as applicants, this is something that programs will look at for your curriculum vitae and CV. And a lot of people, they sometimes have limited time. Publishing research can take a year, if not longer, sometimes. And QI projects can be done within a span of months. I would say one thing that can help people going through this process is finding a mentor. And usually, in many hospitals, even in civil, there are people doing QI projects. So you can find a mentor. You can have a team that can be like a relatively large team. It doesn't have to be like 2 or 3 people limiting themselves because they're writing a case report. You can have maybe 6, 7, 8 or more people. And because of that, you can kind of distribute tasks, participate in multiple QI projects. As Dr. Gulrez Ahmed said, you could present these at conferences. Sometimes people get awards for doing QI projects. So from a resident, an IMG resident applicant perspective, it's relatively low cost compared to a research and high yield. It's easier to do, and it can open the doors for you to do more things. Like, for example, the results of a QI project might make you think about a research study, and you could do that later on. So it's a great way, and something you could do as early as first year, second year, or third year of med school.
Thank you, Mustafa. Dr. Aslam.
Yeah. So thank you, Dr. Jamshed.
Professor, looks like you got muted.
Hi. Thank you, Dr. Jamshed, for a really nice presentation, and Dr. Shah as well for explaining this. Actually, I'm in fellowship right now, and it gives me really nice idea to come up with a new QI project now, because I didn't realize how that QI project was affected patients' life at that time with the anticoagulation. So thank you so much. So I'd say just I echo with what Dr. Shah said. The hospitals and the program directors really look at what you actually do and what how much impactful that is, not rather than just the quantity. They look at the quality of the work that you have done. So if you have a great QI project, you can start working it back in second, third year of medicine or fourth year of medicine, and have more friends working on it. And then you can present it to them, even if you're not able to present it in an online conference. If you can just present it during your interview to them, so that can have a lasting impact on your interview, and program will be looking forward to that as well. And I'd like to mention a little bit about case reports also. What I've seen is people sometimes have 8 or 9 authors on case reports. Coming from my program director, she actually does not like them. She's like, a case report can have 3 or 4, maximum 4 authors on a case report, because it's not like a case series. Okay, if it's a case series, that has a different impact. A case report, 3 or 4 authors is more than enough. So as I said, quality rather than quantity matters the most. Thank you.
Thank you so much, Dr. Khan.
Thank you so much. I believe everything has been covered so far. So just few points which I would like to add. First of all, on QI projects, it also shows the program that you are constantly on the lookout to see what you can improve and how you can improve or optimize the delivery of care to the patient, especially if it's something that's more in which you can save money to the program. That's also something that counts in these QI projects. And secondly, as Dr. Islam mentioned on the case report, number of authorships are very important. The more authors you put, it just somewhat dilutes the system. And I would recommend everybody to just start writing the case reports. It's the easiest thing you can do. Any case, you can just write it up, present it at a conference. It just builds the foundation for higher level of research down the line. Thank you.
Thank you. Dr. Hamid?
Well, I think it was a very good presentation by Dr. Jamshed. It's to the point. I think the big thing is keep it simple, keep it short. Don't make your life hard. They're easy questions that you can answer, easier to collect data, and then get a poster published. The other thing I think it matters is it kind of gives the program director, the associate program director, when you're interviewing, the fact that you're looking at something outside of not just studying in med school and doing like your papers and your passing boards and whatever, but like thinking outside the box, identifying a problem and thinking how you're going to try to fix it. The earlier you start, the better it is, because as you go forward, you start improving. The other thing about case reports is also the same thing. It's easier to write, they're easier to publish. The lesser the people, the better it is, because like the other person was saying, it's not, it's case reports are not hard. You don't need 10 authors on there. So I think today was a very good presentation, and it gives the med students, recent graduates, kind of a start line to kind of how to start and kind of further build on their research.
Thank you so much. So, what I would like to do is to cover letter to editors and case reports because they are very low hanging fruits. I would like to share my own example because that's where I started my career as a research person. So, this is my Google Scholar profile. I was part of a randomized clinical trial upfront. I was very lucky. It's very rare to have a randomized controlled trial upfront in Pakistan. But if you start looking at my other publications, this is a letter, 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 this is actually a paper, this is a letter, this is a letter. And I actually started off my career as a person who used to write letter to editors. And I would love to just look at the topics like weight misperception. Like, what do people think about their weight misperceptions? Continuing medical education. What do people think about CMEs in Pakistan? Polio, a very hot topic. And to be honest, one of these three citations was somebody who worked for WHO, and he wrote a rebuttal to my letter. So it was pretty nice that somebody so senior wrote a rebuttal to my letter. Then Genetian Violet. So this was something that we actually saw within our burns unit at Karachi, and we were using it as an alternate to very fancy medications because this is dirt cheap. So we wrote about it, cutting down on your cola drinks, like talking about obesity, health insurance. Can it work in Pakistan? Childhood pneumonia, can be prevented? And then marital disharmony, psychiatry in Pakistan. So I would go over these one by one, like how to approach a letter to editor. So this was the one that I was super proud about. It has only three citations, but one of the citations is actually a guy who ran the WHO program for polio eradication in Pakistan. And what the structure to the letter to editor looks like, it's very similar to any case report or any other article or retrospective study or something. You usually write to the editors, then you talk about the problem that you're talking about, which is essentially a background, and then you talk about like essentially the problem that you're talking, how big it is, what's the big impact of it. So if you look at it, WHO eradication, then comes the part where what the current situation of polio was at that time. I think this was published back in 2013. So, and then what's the situation in Pakistan right now? And the main part of the letter was how can we make an impact as physicians in Pakistan to improve this situation? So, what we wrote about it is polios need to be eradicated from Pakistan. It might lead to some serious social, it's not, it will lead to social and economic consequences. The government needs to ensure individual and community level demand, overcoming gender barriers, resistant vaccination, reaching out to the poorest and the most marginalized population. Religious clerics maybe can have a significant impact because there is a lot of religious impact in our society, maybe involving them in that process. So essentially, we just wrote a couple paragraphs based on our background search of a topic, and it got published in the Pediatric Infectious Journal, which I think has an impact factor of 1.7 or something. Another example. So this was a letter to editor again, continuing medical education, what people think about in Pakistan about CMEs. We did not have the CME requirement at that time by PMDC, which is now a requirement, but essentially the same thing. What does CME mean? What value does it add? What are the current limitations within the system right now, and how can we address them? These are all publicly available. You can read it, you can get some good ideas from it and see how you would like to structure them. Same goes for, okay, this is not available as a PDF, so I'll move on from this one. But essentially, it's just that you talk about the problem, you do a literature search, see what are the potential solutions that have been recommended, summarize them in a single letter, and then get it to a publication. So, very easy. Same goes for case reports. Like as Dr. Aslam alluded to, there are only four authors here. Myself, a couple more people, and then Dr. Wasif Saif, who is at Northwell currently in New York, who's a hemong attending. And you have to write an abstract. Abstract is essentially a summary of what you have presented in your work. Then you write about a little bit of a background. Background is essentially what the problem is and why did you come up with this idea or why did you have to talk about it. It's essentially a punchline, your aim or your objective of the case report that you write. Then you describe the case. This is a 42-year-old Caucasian female, significant weight loss, had their CT scans done, was found to have adenocarcinoma of colonic origin. We mentioned some testings, we mentioned everything else. So you go on, you mention the whole case, you kind of like try to cover everything, you add photos to add validity to your study. to show that the problem that you're addressing was actually a problem. Then you try to add CT scan films, you try to add more pictures. This is post treatment, how the lesion is healing. And essentially, that's what we did. We talk about the case that we managed in our OPD while just managing the patient. I got a publication out of it. Then you do a discussion part. Discussion part is essentially going over what has already been published. And what I usually like to do is I like to summarize the current data on it. Top-notch studies which have been published. Try to see if you can summarize all of them in a single table, because that adds value for a journal. क्योंकि देखो, when you're trying to publish for a journal, you need to make sure that the journal can get citations out of it. That's how they actually collect prestige over time, because that improves their impact factor. So essentially went in, did some literature search on PubMed, found like 10 or 15 cases, reported all of them in this case review, and essentially made it a review article within a case report. And the journal loved it and they published it at a very short interval. And then you finish it off with the conclusion that what was your impact from this paper. So these are very easy things. Day in, day out, as long as you remain clinically relevant, you will see cases that are worth writing. You can write them up as posters, you can write them up as publications, but essentially you can go to any of our profiles right now, go on Google Scholar, find our names, and you will be able to see what we have been talking about and what we have been publishing. Now I publish a lot more different things. I go towards more retrospective and prospective work, as compared to letter to editors. But this is how started my career. I literally started off my career with letter to editors and case reports. So these are very low hanging fruits, very easy to approach. You don't need very in-depth knowledge of statistics. You can literally just sit in. As long as you have an internet, you have a computer, you can sit down, think of a topic, start working on it, get an input from a mentor, identify a journal, and get them submitted. Mustafa has raised his hand.
Hi. That was a great overview, Dr. Gurrizbay. Um, I think all of us, many of us would have started with our research journeys with LT letters and case reports. One thing I would just add for the current generation in like 2025 and everything is that um, previously journals were more willing to publish case reports alone, like without a literature review, but nowadays many journals they're not publishing just sole case reports. They want a literature review, like you did for
Mhm.
this case of the skin cancer. And the other thing is some journals are not even accepting like case reports at all, like particularly
Yeah,
higher impact journals, that's only by invitation. So for students
that's true.
or trainees who want a publication, I would recommend that they first look up in that topic or subject matter, like look up similar case reports, similar publications, which journals are publishing it, what those journals requirements are, so that you know where you're aiming at and you can kind of tailor your write up and your case similar case profile and meet their requirements, like if there's any HIPAA authorization or any, they usually don't need IRB, but whatever the journal requires, you can kind of have that set up in advance rather than preparing a case report, thinking that you will give it in journal X and then realizing journal X stopped accepting case reports 5 years ago. And similarly for like letters, I think there surely are many journals that accept them, but you should kind of chart out where you want to end up and then work stepwise to get there.
Dr. Jamshed?
Yeah, I totally agree with Dr. Shah. This has been a new, more recent development that they're not accepting case report publications. Now, you can still do case report for posters. I'll share one that was very simple that one of our fellows got or a presidential poster. It's a very simple thing, and you can see there's only 3 authors. We had a patient who came in with a specific type of dermatitis that we typically only see in pediatrics, but we saw it in geriatrics. She was 88, but you can see that we have edits, and like Dr. Shah pointed out, you need references. Okay. The other one that we did was actually a publication, and I can briefly tell you the story of that is that the first time I submitted it, it was rejected. And I emailed them back and I said, you know what? I think that this is important and it's worth doing it again. So they said, okay, you can resubmit it. So then we worked on it again, and fortunate to have a publication, like an actual, this is just the abstract, but we have a whole publication on this case report. This is very hard to do. It took us 2 years to get this published. So for your timeline, it's very few journals which will accept a whole publication, focus more on case reports. You can see there's Syed Tabish Rahman. He was an IMG at that time from one of the schools. And then in the other one that I showed, so I always try to get one person. They cannot access HIPAA stuff, right? They cannot access the actual patient information. So that has to be written by the person who's taking care of the patient, like who's involved in the care. You can't just make it up. And the other people, however, can help with the writing part and the research part and things. So
I
just
agree.
just some input.
Yeah, you at least need one person to identify a case who has access to chart, but anybody else can contribute to those cases. Another thing is when you share pictures, you're not supposed to, you try to de-identify them as much as possible. You at least cover their eyes, you cover their mouth so that nobody's able to identify them completely. There are many ethics. There is a lot of opportunity for any one of you to work on things. Especially in a country like Pakistan, where very basic things are lacking at the moment, you have a big opportunity to work any of those opportunities. I think we are almost at the end of our hour. Anybody who has any questions, we can take extra 5 minutes because we did start 3 minutes late. So anybody who has questions can raise their hands and we can give them the mic to ask questions. If not, then we will end the session then. Anybody? All right, doesn't look like anybody has any questions. Let's just take last final thoughts from everybody, all of our panelists, and then we'll end the session. I'll start off with Mustafa. Mustafa, you're muted, but let's just give Dr. Jamshed a few seconds and then she can leave.
I'm sorry, I have to leave, but I don't. I all I wanted to say is, what Dr. Ahmed will tell you, that if any of you have a QI project you want to do and come up with an aim statement, we're happy to help. You will have to do all the hard work, but we're happy to review it and help you come up with an aim statement and intervention. But remember, we're not talking about research. We're not talking about anything huge. We're talking simple QI projects that you can publish as case reports. Okay. So thank you very much. Dr. Gulrez Ahmed will share anything that is important with you. And thank you for listening to me.
Thank you
Okay,
so much. Have a good day. Allah Hafiz. Mustafa.
Hi. So this was an amazing session. I think if I had heard this session in my first year, second year, I would have gotten working on QI projects and case reports much earlier. And I'm hoping that APPNA and YPC will keep doing more events to like further knowledge about different research avenues in QI projects. And we're happy to keep supporting our young medical students and trainees in Pakistan.
Thank you so much, Dr. Khan.
Thank you for having me here. I would just want to add one more thing in terms of the applicants who will be submitting their case reports. There are still few journals out there that do not charge you anything. They're just new, starting up. So look out for those journals so that you can just submit your case reports and have publications. Thank you.
Dr. Hamid.
Yeah, I would just say start. The earlier you start, the better it is. And if you have questions, feel free to ask. Don't be hesitant. Don't be shy. We're here to help you guys. We've been through the same path. And yeah, just keep it simple, keep it easy, and just get a poster out of it. The least is what you can do.
Thank you, Dr. Aslam.
Great session organized by APPNA YPC as always. I really appreciate that they are looking at the minute things that can be easily picked up by early career students so that they can get into the residency programs. So I'd like to point out one more thing is some conferences, they don't need any they'll just publish most of the posters without charging you any fee. Like Soho. When I went to Soho Society of Hematological Oncology conference, I saw a lot of case reports there. On their website, they say they don't publish case reports, but they say they had a lot of case reports from different countries: Yemen, Sudan, Egypt, all those. And then also Lymphoma, Leukemia, Myeloma Society conference, that's also coming up. Both of these are coming up. So if anybody wants to get some publications done, it's very easy to get the publications done on both of these. And lastly, the QA projects, very meaningful, very impactful, and they go a long way.
Thank you so much. So we are available. We can help you out with anything that you need. But to be honest, we do have our lives outside of this world as well. What I would say is use our Facebook page. If you have any specific questions, just post it over there, and I bet you will find at least 10 to 15 people who are willing to help you out, write up an A statement or review your paper that you have written. So what I would do is I will use that APPNA YPC page as your best resource to seek mentorship. Of course, you can reach out to any one of us as well over Facebook. We all are public. Will you get a response or not? Totally depends on our day. If you're having a good day, maybe you might get a response. If you're not having a good day, you might not get a response. But I would use the Facebook group as a very good resource to share your ideas and see how we can help you build on it further. Rest. It was a wonderful session. I hope you all learned from it. We will think about the recording part. I was hoping to keep this as an interactive session that we do frequently every few months rather than just putting everything online because nobody watches them online. We can clearly see that there is not much traction that we get from our recordings that are uploaded, even though people ask for it all the time. But we'll think about it as a bigger team. This is APNA YPC. All of these guys are members of the APNA YPC this year. And I hope we can continue to make changes in your lives and improving outcomes for all our people back home. Take care, everybody. Allah Hafiz.